Thanks for your kind introduction. I'm very pleased to meet you all, and it's a great honor for me to give a lecture in front of you in the Dental Minimalism consensus today. With the introduction of dental implants, oral surgery has become much more common even in general practice. But as many of you know, the maxillofacial region, especially the posterior maxilla, is still a challenging area for both general practitioners as well as even for specialists. Why is the posterior maxilla considered one of the most challenging regions for implantology? This is because the posterior maxilla is an area notoriously known for both poor bone quality and limited bone quantity, which inherently comprises primary implant stability. Because of these severe limitations, in many cases, sinus augmentation is needed. However, as you know, sinus elevation has traditionally been considered one of the most challenging and highly invasive procedures in all of implant surgery. All surgical techniques are moving toward less invasive procedures. Think of it like open abdominal surgery, great visibility, but more complications and scarring. Recently, robotic and laparoscopic surgeries have become popular because they are less invasive. What is your choice? Today, I will guide you through the evolution of maxillary sinus augmentation, minimal invasive sinus augmentation using dual computer guide system. First, I would like to begin with discussing what patients want when they visit our clinic. I suppose they want to have painless treatment, avoid any kind of risks, and wish to have a short treatment as well as wish to hear detailed explanation before the treatment. Computer-guided surgery may make these wishes come true since it allows us to perform flapless surgery and place the implant to the optimal ideal position as well as allowing us to avoid vital anatomy and have a virtual simulation before surgery. In this context, if possible, flapless implant placement is the best, simple and safe. Needless to say, flapless surgery using a computer guide has many advantages. Nevertheless, it is hard to encounter such an ideal patient who has enough bone quantity and enough keratinized tissue. Where is good for flapless surgery in our mouth? Generally, anterior aesthetic zone has narrow alveolar ridge after tooth extraction, and subsequently, loss of keratinized soft tissue as well as hard tissue occurs. What about the posterior mandible? Because mandibular posterior region has wide alveolar ridge width, it is good for flapless surgery in hard tissue level. However, we frequently encounter often thin band of keratinized tissue in mandibular posterior region. It might be a relative contraindication of flapless surgery. What about the posterior maxilla? In general, you can find wide width of alveolar ridge and wide band of keratinized tissue. Here is the best indication of flapless surgery. However, as I mentioned before, the posterior maxilla has often some limitations in available bone height due to pneumatization of the maxillary sinus. In many cases, sinus augmentation procedure is needed. In case of a flapless surgery, if we don't use a computer guide, we cannot see the bone crest level. Drilling depth should be determined by soft tissue level as a reference point. It's not accurate. Because the visibility and the accessibility are poor in the posterior maxilla, sometimes it is very difficult to adjust the delicate drilling depth by freehand without drilling stop. In order to solve the problems, I have developed Flamney's sinus augmentation technique using a computer guide, which is another implant company in Korea. I will skip the detailed procedure due to the limited time assigned to me. This technique was highly innovative and creative in minimal invasiveness in the posterior maxilla. 3 papers were published using this system. While this system demonstrated excellent clinical outcomes, it did come with several notable limitations. First, to control the drilling depth after placing the computer guide, I had to insert an additional metal sleeve. The instrumentation was quite complex and sometimes lead to confusion, which meant it required a significant learning curve to truly master. Moreover, the procedure required switching between multiple instruments. This meant we had to repeatedly attach and detach the computer guide for many times, which was quite cumbersome during surgery. Another major issue was the limited inter-arch space when walking in the posterior region. Because of the combined height of the guide itself, the metal sleeve, and the long drill, I sometimes couldn't gain proper access at all. But most importantly, the biggest drawback was that in order to use this guide system, clinicians were required to purchase a dedicated proprietary milling machines. I spent a lot of time thinking about how to overcome these challenges. Then, one day, I had a sudden realization. What if we simply separate the guides? I realized that fabricating a drilling guide and a placement guide separately could easily solve this problem. Here is how it works. For the drilling guide, we plan the procedure using the shortest implant, which is a 7 millimeter in bright implant system. You can simply ignore the position of the implant top. Instead, your only focus is on accurately targeting the implant apex. I specifically designed the guide so that the drill tips stops exactly 0.5 millimeter below the sinus fluid. After this sequential drilling, I removed the guide, and you can find a very thin layer of bone remains intact just below the sinus membrane. This thin bone sealing can be easily and safely elevated using either a compaction drill or an osteotomy for the crestal approach. Then, bone grafting can be performed through the drilling path as usual. Now, this is the placement guide. This guide is designed solely to position the top of the implant exactly at the bone crest. Because I have already standardized the position of the implant top, you have complete flexibility. Since the sinus membrane is already elevated, you can choose and place an implant of any length you need, whether it's a 7 millimeter or 9 or 11 millimeter, whatever. Currently, I'm conducting a randomized controlled clinical trials based on this concept. To be specific, this is a pilot study designed to compare two different bone substitute, particulate and collagenated xenograft, while the primary objective is to compare these two different biomaterials. I made an interesting addition to our protocol. In case where patients have sufficient keratinized mucosa, I decided to perform a flameless sinus augmentation, utilizing a dual guide system I just described. Now, let me show you some cases enrolled in this project. In this first case, the patient had previously undergone a medial buccal root amputation on tooth number 26. However, due to progressive bone loss and pain in this area, the tooth eventually had to be extracted. These are the preoperative clinical situation. As you can see here, the patient has a sufficient amount of keratinized tissue. Using the CBCT data, I established two separate plans and fabricated two distinct computer guides, one exclusive for drilling and the other for implant placement. Let's look at the drilling guide first. I positioned the template for our shortest implant, which is 7 millimeter. I carefully aligned it so that the drill tip stops exactly 0.5 millimeter short of sinus floor. Therefore, even if I drill to the full depth using a 7 millimeter drill, there is absolutely no risk of damaging the sinus membrane. Next is the placement guide. Here, I adjust the height so that the top of the implant aligns perfectly with bone crest level. In this case, I utilized a bright tissue level implant, so the guide was calibrated accordingly. Because this guide standardized the position of the implant top at the crest level, the actual length of the implant you place, whether it's 7 or 11 millimeter, does not matter at all. The surgeon simply chooses the appropriate length based on their clinical preference or decision. By using this guide, the implant will always sit exactly at the planned height. The drilling protocol will proceed as follows. First, I used a tissue punch to carefully remove the soft tissue. First, I placed the drilling guide and used a tissue punch to mark the exact site. Then, I temporarily removed the guide to easily take out the punched soft tissue. Once the underlying bone crest is fully exposed, I reposition the drilling guide and proceed with the actual drilling. As you can see here, the drilling sequence follows the step highlighted in the red dotted box. The surgical engine is set at 1,000 RPM and drilling is performed sequentially until reaching the final drill that corresponds to the planned implant diameter. In this clinical case, since a 4.5 millimeter diameter implant was planned, the drilling sequence was completed up to the blue coded drill. Although the surgical kit contains many drills, you only need to use the 5 drills in the top row sequentially. As these are the shortest drills available, they proved highly advantageous for surgical access in the posterior maxillary region, particularly in cases presenting with restricted interarch space. Let me review the actual surgical workflow video clip. First, the drilling guide was seated to mark the site with a softish punch. After temporarily removing the guide to excise the tissue, the guide was repositioned. The 7mm drills were used sequentially, stopping just one step before the final drill. And it's just the 4 steps of drilling. It's simple and fast. The depth gauge was then introduced to tactilely verify the sinus floor. To safely penetrate the sinus floor without damaging the membrane, a dedicated blunt-tip drill was utilized in this case. I should mention that this specific drill is from another manufacturer. This crystal drill was applied at low RPM without saline irrigation under gentle pressure. If you look closely, you can see autogenous bone chips naturally harvested on the drills. Upon confirming sinus fluid penetration, hydraulic pressure is employed for membrane elevation. By repeatedly injecting and withdrawing saline from the syringe, I carefully and gradually elevate the delicate membrane. After removing the silicone tube, I can observe something very interesting. With every breath the patient takes, you can see the pooled saline inside, the sinus fluctuation, and coming out. The same procedure was repeated. Injecting and withdrawing the saline. Once adequate elevation is achieved, I performed the final drilling for the 4.5mm diameter implant. Then bone grafting was followed. Since this patient was randomized into the osteogenital particulate group, I grafted the material in small increment. For this step, you can comfortably use either a conventional condenser or an osteotome. Additionally, osteotome was also used. This video is minimally edited to show you actual full length of the procedure. After bone grafting was complete, it's the placement guide time. Then switching to the placement guide, I successfully placed a bright tissue level implant. For the delicate depth control, I used a manual wrench. Look at the tight primary stability. And finally, the small cover screw on top was removed and a healing abutment was connected. By utilizing this dual guide technique, I was able to perform a flapless sinus augmentation and simultaneously place the implant exactly in our planned position. These are the clinical photographs taken after 1 week and 1 month of healing. As you can clearly see, the soft tissue around the implant was healed beautifully, showing a very healthy condition. At 4 months postoperatively, the final restoration was successfully delivered. This intraoral scan video presents the clinical views recorded 6 months post-surgery. These are serial X-ray images. You can notice that the initial dome-shaped mass has dispersed, resulting in a flatter, more natural contour. Furthermore, the demarcation between the grafted material and the native bone is progressively consolidating, which indicates excellent osseous integration. Look at the CBCT images. In the CBCT taken right after surgery, some haziness was observed of the augmented mass. It is assumed to be due to the remained fluid because of the hydraulic method used during surgery. At 6 months, clear bone augmentation and healthy sinus mucosa were evident around the implant. Now I would like to present another clinical case, this time utilizing osteogenocollagen, collagenated xenograft. Looking at the preoperative X-rays, you can observe a septum on the medial aspect of the surgical site, as well as a sloped sinus floor. Additionally, there was a slight thickening of sinus membrane. Clinically, however, the inter-arch relationship was acceptable and a sufficient width of keratinoid tissue was observed. As previously detailed, I proceeded with the dual guide planning, successfully fabricating both the drilling and the placement guides for this procedure. These clinical photographs show the surgical site immediately after removing the soft tissue with a soft tissue punch. Following this, I proceeded with the guided drilling using the same protocol as in the previous case. This patient was assigned to the osteogenocollagen group. For preparation of the bone graft, I hydrated the osteogenocollagen block and used a surgical blade to divide it 4 small pieces. On the right, you can see the clinical situation immediately after completing the bone grafting. From now on, you should switch the placement guide. This shows the placement of 4.5 by 9 millimeter bright tissue level implant, which was guided precisely into position. If you look closely at the post-placement photo, you can clearly observe that the implant is positioned exactly centered within the surgical guide. This perfectly demonstrates the accuracy of the dual guide system. The entire process, from the initial soft tissue punch to connecting the healing abutment, took merely 15 minutes. Furthermore, there was almost no bleeding around the surgical site, which truly highlights just how simple and safe this procedure is. Here, you can see the panoramic X-ray taken immediately post-op. And here are the clinical views at 10-day follow-up. A major clinical advantage of eliminating suture is that patients are able to maintain their oral hygiene by brushing immediately post-surgery. As you can see, the tissue has healed beautifully with absolutely no swelling or signs of inflammation. It recorded 77 when measured using the Dentium Trust device, an implant stability damping device. At 3 months, the score rose up 87 and healthy peri-implant tissue was found. The final prosthesis was delivered 3 months postoperatively. This intraoral scan demonstrates the clinical presentation at 6 months follow-up. Here we can see the sequential X-ray images immediately after the surgery at 4 months and 6 months. Next are the CBCT images over time. Despite the presence of anatomical complexities, namely a septum and a sloped floor at the surgical site, successful sinus augmentation was accomplished with an intact membrane and zero perforation. At the 6 months evaluation, a significant volume of augmented bone was evident. Now, let's take a look at the surgical time. Due to the total absence of incision, flap elevation, and postoperative suture, the overall surgical duration was exceptionally brief, averaging approximately 12 minutes. Regarding the grafting materials used, the osteogenocollagen group, which comes in a block form, demonstrated a shorter bone grafting time, thereby providing superior operator convenience. In summary, the dual guide system allows us to perform minimally invasive flapless sinus augmentation, seemingly combined with simultaneous implant placement. This approach significantly reduced both our surgical time and the risk of biological complications with high accuracy. Provided that the guides are precisely planned, the actual surgical protocol is incredibly simple and highly intuitive. It has a very short learning curve, meaning anyone can easily learn and reproduce this result. Furthermore, guided surgery is possible even in the posterior cases with limited inter-arch space. As a final note, I'm pleased to announce that the International Perio Congress is scheduled to take place in Seoul National University on October 23rd of this year. We highly encourage all interested colleagues to register and participate in this upcoming event. Thank you once again for taking your time and attention today. Thank you.